All right, let's dive into this. Looks like a whole syllabus on respiratory therapy, so we're going deep on pharmacology today.
Yeah, should be a good one. Definitely a lot to cover.
For anyone listening who's maybe prepping for class or just needs a refresh, get ready for a crash course. We're about to uncover some pretty surprising stuff. Like, ever heard of the lock and key principle?
Oh yeah, that's a classic way to understand how drugs work in the body. Basically explains how medications interact with receptors.
Exactly, and we'll talk about that. Plus, we'll get into how certain medications can act like, I don't know, superheroes or supervillains almost.
You mean agonists and antagonists?
Yeah, those guys. How they affect our nervous system, especially when it comes to breathing.
Definitely important stuff for respiratory therapy.
We'll even touch on those fascinating neurotransmitters, the ones like epinephrine, norepinephrine, acetylcholine. But first, before we get too ahead of ourselves, let's start with how our bodies process these chemical messengers in the first place.
So the pharmacokinetic phase.
Exactly, like what happens to a drug once it enters our system.
Right, so basically what your body does to a drug.
Makes sense. But how do we even keep track of all the things our body does to a medication? It seems like a lot.
Well, there's a handy acronym. DAM stands for distribution, absorption, metabolism, and elimination. Think of it like a journey the drug takes through your body.
I like that, a drug's journey. So where would distribution fit into this journey?
It's the first stop, really. Distribution is how the drug gets around in your body, traveling through your bloodstream to reach different tissues and organs. Then comes absorption, which is how the drug actually gets into your bloodstream.
So if you swallow a pill, absorption happens in the stomach.
Yeah, for the most part.
Yeah.
But different drugs are absorbed in different parts of the digestive system. It's not always the stomach.
Gotcha. So after absorption, then what?
Then we have metabolism, where your body starts breaking down the drug. Happens a lot in the liver, getting it ready for elimination.
Elimination, that's like the final exit point, right?
Yeah, usually through your kidneys.
Okay. DAME distribution, absorption, metabolism, elimination. Got it. That really helps me visualize how our body actually processes all these medications.
Yeah, it's a good framework, but then there's the next phase, which is all about what the drug does to your body.
Pharmacodynamics, right?
Exactly.
All right, so the drug has arrived at its destination. Now what?
Now things get really interesting. We start talking about agonists and antagonists. And you remember that lock and key principle?
Yeah, bring on the locks and keys.
Right, well, imagine a receptor in your body is like a lock, and the drug is a key. An agonist is like the perfect key. It fits into the lock, turns it, and something happens.
So an agonist activates the receptor, like it makes something happen.
Precisely. Now, an antagonist is more like a key that fits into the lock, but it can't turn it. It's blocking the lock, so the agonist can't get in.
Antagonists are like blockers, then.
You got it. This concept is super important in respiratory therapy because a lot of medications work by targeting specific receptors in the lungs. Like some asthma medications are beta-2 agonists, acting as keys that unlock specific receptors in your airways, causing them to relax and open up.
So you can breathe easier. That's fascinating, a real-life example of how agonists work. But how long do those effects last? I mean, the key can't stay in the lock forever, right?
That's a great question. It brings us to another important concept, dissociation half-life. It's just a way of saying how long it takes for half the drug to detach from its receptor.
Like the key coming out of the lock? So the longer the dissociation half-life, the longer the drug's effects will last.
You got it. That's why some medications need to be taken several times a day and others just once.
It all depends on how long they're bound to those receptors. This is really making me think about the medications I take and what might be going on in there.
Right. It's a different way of looking at things.
Absolutely. Now let's shift gears a bit and talk about the nervous system, especially since we're focusing on respiratory therapy. I remember learning about the sympathetic and parasympathetic systems, but it's been a while.
Yeah, those are key players.
Could you give us a quick refresher on those two systems?
Sure. Think of them like two sides of the same coin. Both control automatic functions in your body, but with opposite effects. The sympathetic nervous system is all about fight or flight, getting you ready for action.
So like when you encounter a bear in the woods.
Exactly. Your heart rate speeds up, breathing increases, your pupils dilate, and your airways open up. Also, you can get more oxygen and be ready to run.
Wow. It's like our body's own internal alarm system. What about the parasympathetic system?
That's the rest and digest system. It promotes relaxation and recovery, slows down your heart rate, constricts your pupils, and narrows your airways, the opposite of fight or flight.
So it's like the calming influence after the storm.
Precisely. And these systems are always working together, trying to maintain balance in your body.
It's amazing how our body can automatically adjust between those states depending on the situation.
It's pretty remarkable for sure. And a lot of medications, especially those used in respiratory therapy, work by influencing these systems.
Oh, so some medications can either enhance or block those sympathetic or parasympathetic effects.
That's right. Some medications for asthma, for example, target the sympathetic system to open up those airways. And some medications for COPD target the parasympathetic system, to try to keep those airways from constricting.
So it's all about understanding those pathways and how we can like manipulate them to help people breathe better.
Exactly. That's a great way to put it.
This is starting to make a lot more sense now. So let's break down how medications actually work on the sympathetic nervous system, those fight or flight responses.
Okay, so within the sympathetic nervous system, we have these things called adrenergic receptors. They're kind of like tiny targets that medications can aim for.
Targets, okay?
And these receptors, they're further divided into alpha and beta receptors. Each one has its own specific role to play.
So alpha and beta receptors are both part of that sympathetic system, but they do different things.
Exactly. Okay, so imagine you're at a concert, the music is really loud, and everyone's super hyped up. Alpha receptors are like the security guards, trying to keep things under control by constricting your blood vessels.
To keep everyone safe.
Yeah, and to help maintain your blood pressure, prevent you from fainting.
So alpha receptors are the ones that kind of tighten things up.
Exactly. They're like the keep calm and carry on crew. Now, beta receptors are more like the excited fans, getting pumped up by the music. You have a bunch of different effects, but one important thing they do is relax the muscles in your airways.
So beta receptors are the ones that open things up.
Precisely. That's why those beta-2 agonists are so important for treating asthma. They target those specific beta-2 receptors in the lungs, helping to open up those airways, so you can breathe.
This is making so much more sense now. So medications can either stimulate those receptors, which we call adrenergic effects, or block them, which are the anti-adrenergic effects, right?
Exactly. It all depends on what you're trying to achieve. Like beta blockers, which are used to treat high blood pressure, those are anti-adrenergic drugs. They block the effects of adrenaline on beta receptors, so your heart rate slows down and blood pressure drops.
Wow, that's a perfect example of how we can actually manipulate these systems. But it's important to remember that beta receptors aren't all the same, right?
Good point.
I mean, we have beta 1 and beta 2 receptors, and I'm guessing they're not just hanging out in the same place.
No, they're not. Beta-1 receptors are mainly found in the heart, and stimulating them increases heart rate and contractility. Beta-2 receptors, those are primarily found in the lungs, and stimulating them relaxes the airways.
So bronchodilation.
Yes.
So if you're using a beta 2 agonist for asthma, you're targeting those beta 2 receptors in the lungs, but leaving the beta 1 receptors in the heart alone.
Precisely.
Wow, this is really making me think about how complex this all is.
Yeah, it is. And we've only just scratched the surface of the sympathetic nervous system. We haven't even gotten to the parasympathetic system yet.
Well, I'm definitely ready to dive into that.
All right, let's shift gears then and explore how those medications can influence the rest and digest system. Remember acetylcholine?
Oh, yeah. That's the main neurotransmitter for the parasympathetic system, right?
Exactly. And just like with the sympathetic system, we have medications that can either stimulate or block the effects of acetylcholine on those specific receptors.
Okay, I'm following.
The medications that stimulate acetylcholine receptors, we call those cholinergic drugs, and the ones that block them are called anticholinergic drugs.
So it's similar to agonists and antagonists, but specifically related to acetylcholine and that parasympathetic system.
Precisely. And just like with beta receptors, there are different subtypes of cholinergic receptors, and each one has its own unique role.
Okay, so I'm guessing some anticholinergic drugs can target those specific receptors in the airways, to prevent them from constricting?
That's exactly how some medications for COPD work. They block those effects of acetylcholine on those receptors in the airways, helping to keep those airways open.
So people with COPD can breathe better. It's amazing how we can target these very specific receptors.
It is pretty amazing. It all comes down to understanding those pathways and how things interact, which is really the foundation of pharmacology, especially for respiratory therapy.
And we've covered a lot of ground already, like from those phases of drug action and the roles of agonists and antagonists to those intricate workings of the nervous system and how medications can influence both the sympathetic and parasympathetic sides.
We have, yeah. But it's just the beginning. There's so much more to explore.
And I'm ready for it. But before we get too far ahead, I think we should talk about the more practical side of things.
Yeah.
Like, Knowing how drugs work is one thing, but knowing how to actually use them safely and effectively is another.
Absolutely.
So let's jump into that.
Let's say you're getting a medication ready for a patient, and you see the doctor ordered a 0.083% solution.
Okay, 0.083% solution. That sounds familiar, but how do we actually figure out how much medication is in there?
That's where those drug calculations come in. So 0.083% means that for every 100 milliliters of solution, there's 0.083 grams of the actual drug.
So it's a way of expressing the concentration. So if I had like 200 milliliters of solution, I'd have doubled the amount of the drug, right?
Exactly. And being able to do those calculations, quickly and accurately is really important, especially when you're dealing with patients. You need to make sure you're giving the right amount.
It's like baking a cake, you know? You gotta have the right proportions of ingredients to get the desired result. Too much or too little of something can really mess things up.
That's a great analogy. Now, beyond those calculations, we also have to think about the different ways we can give medications to the body.
Right, like how we actually get those medications into the system. We've talked about inhaled medications, which are obviously super important in respiratory therapy, but what are some of the other options?
Well, you've got the oral route, which is just taking medications by mouth, like pills, capsules, liquids, that sort of thing.
Probably the most familiar for most people. Just pop a pill and you're good to go.
Yeah, it's convenient, but it has its limitations. Some medications get broken down in the stomach before they can be absorbed, so they might not be as effective.
So sometimes taking something by mouth isn't the best way to get it where it needs to go.
Exactly. That's why we have other routes of administration, like those intravenous injections.
5e, yeah. So that goes straight into the bloodstream.
Yes, it bypasses the whole absorption process,
Mhm.
often used in emergencies or when you need a medication to act really quickly.
Definitely much faster than waiting for something to be absorbed. What about intramuscular injections? I remember getting those as a kid.
Yeah, IM injections. So those are given directly into a muscle. They tend to have a slower, more sustained release of the medication compared to IV.
So depending on the situation, different routes might be preferred.
Absolutely. It all depends on the specific medication, the patient's condition, and how fast you need it to work.
It's like choosing the right mode of transportation. Sometimes you need a fast train, and other times a scenic bike ride will do.
I like that analogy.
Huh?
Now, there's one more route I want to mention. This one's reserved for those really intense emergency situations when you absolutely can't get IV access.
Oh, this sounds intense. What is it?
It's called intraosseous administration.
Intraosseous, okay.
So you're injecting the medication directly into the bone marrow.
Wow, directly into the bone. That sounds pretty hardcore.
It is, but it can be life-saving when there's just no other way to get those meds into the bloodstream fast enough.
It's incredible to think about all the different ways we can get those medications into the body. It's like having a whole toolbox of options.
It is. Now let's shift gears a bit and dive into the world of medications that are specifically used for respiratory conditions. This is where it gets really interesting.
Oh, I'm ready. I know there are tons of different medications out there, each one targeting a different aspect of breathing problems.
You're right, there are. We have bronchodilators to open up the airways,
Yeah.
mucolytics to thin out that mucus, corticosteroids to reduce inflammation, and even nonsteroidal anti-asthma agents for long-term control.
It's like having a whole team of specialists working together.
Exactly. And within each of those categories, there's a whole bunch of individual medications, each with their own unique way of working, their own potential side effects.
Right, it can get complicated. Let's start with those bronchodilators, since they seem to be the superstars of respiratory therapy. I know we talked about beta-2 agonists earlier, like albuterol. Are there other types of bronchodilators?
Yeah, there are. Another important group are those anticholinergics, like ipratropium bromide and tiotropium bromide. Remember how we talked about acetylcholine and its role in the parasympathetic nervous system?
Yeah, that's the neurotransmitter that's all about rest and digest, which includes constricting the airways.
Right. So anticholinergics block those effects of acetylcholine on those receptors in the airways, and that prevents bronchoconstriction.
So they're basically like putting up a do not enter sign for acetylcholine.
Exactly. They're preventing those signals that would tell the airways to tighten up.
That's so cool. I actually used ipratropium bromide when I had a really bad cold once, and it really helped me breathe.
Yeah, it's often used as a rescue medication for COPD, and tiotropium bromide is a longer-acting version, more for maintenance therapy.
So some bronchodilators are for quick relief, while others are more for long-term control.
Exactly. And sometimes they're combined for an even stronger effect, like Combivent, which combines albuterol, a beta-2 agonist, with ipratropium bromide, the anticholinergic.
So it's like they're joining forces.
Exactly.
Yeah.
Now, there's one more type of bronchodilator I should mention, and those are the methylxanthines, like theophyllanines. They work a bit differently, relaxing those airway muscles and also suppressing inflammation.
Theophylline, yeah. I think I've heard of that one, but it doesn't seem to be used as much as the other ones.
You're right, it's not. Theophylline can be a little tricky because it has a narrow therapeutic window, meaning there's not a lot of wiggle room between an effective dose and a toxic dose. And it interacts with a bunch of other
This
medications.
requires some pretty careful monitoring.
Yeah, definitely not the first choice for most people.
Makes sense. Now, what about those mucolytics? They help to thin out mucus, right?
Exactly, they do. So they're really helpful for conditions like cystic fibrosis, chronic bronchitis, and pneumonia, where that thick mucus can really clog up the airways.
I've heard of mucomist. Is that a mucolytic?
Yes, Mucomist is the brand name for acetylcysteine. It breaks down those chemical bonds in the mucus, making it less sticky and easier to cough up.
So it's like a pair of chemical scissors snipping apart those sticky strands.
That's a good way to put it. Then there's Dornase alpha, also called pulmozyme, that was specifically used for cystic fibrosis.
Okay, so what makes that one special?
Well, it actually breaks down the DNA in the mucus, which helps to reduce its stickiness.
Hmm.
Pretty specific mechanism of action.
It's amazing how these meds can target such specific components of mucus.
It is. And sometimes you don't even need medications. You can use something as simple as hypertonic saline.
Saline, like the stuff you use to rinse your nose?
Yep, exactly the same stuff. But for this, we're talking about a more concentrated solution that you inhale. It draws water into the airways, which helps to thin out that mucus.
So it's like giving the mucus a big drink of water.
Exactly. Simple but effective.
All right, let's move on to corticosteroids, which are kind of a big deal in respiratory care. I used inhaled corticosteroids when I had asthma as a kid.
Corticosteroids are definitely powerful. They suppress that inflammatory response. They work by reducing swelling, mucus production, and that airway hyperresponsiveness.
So they're like peacekeepers, calming down that inflammation.
Exactly. They come in several forms: inhaled, oral, and even intravenous.
But inhaled corticosteroids are the way to go for long-term management of asthma and COPD, right?
They are. Because you're delivering the medication straight to the lungs, it minimizes those systemic side effects. Some common ones are beclomethasone, fluticasone, budesonide, and mometasone.
Fluticasone, that rings a bell. I think that's the one I used.
And just like with those bronchodilators, we often combine corticosteroids with other medications for better effect, like Advair, which combines fluticasone with salmeterol, that long-acting beta-2 agonist.
Right, those combination inhalers, so you get two medications at once.
Exactly. Simplifies things for the patients and helps them get better control of their symptoms.
Now, I've heard of something called nonsteroidal anti-asthma agents. What are those all about?
So those are a group of medications that are used for long-term control of asthma, and they work by targeting different pathways involved in inflammation. They provide some good alternatives for people who maybe don't respond well to those inhaled corticosteroids or need something extra.
Like a backup team.
Yeah, think of it that way. One group are those mast cell stabilizers, like cromolyn sodium and needcromyl sodium. They work by preventing the release of those inflammatory mediators from mast cells.
Which are involved in those allergic reactions.
Exactly. Then you have the leukotriene modifiers like montelukast, zafirlukast, and ziluton. Those block the action of leukotrienes, which are also potent inflammatory mediators.
So they're intercepting those inflammatory messages.
Right. And then we have omalizumab, which is a monoclonal antibody that targets immunoglobulin E, or IgE. That one's used for severe allergic asthma.
Wow, so many different ways to target inflammation.
It's pretty incredible how much research goes into treating asthma.
This has been such a helpful overview of those respiratory medications.
Yeah.
But before we move on, we should talk about monitoring medication effects. How do we know if those medications are actually working?
Good point. Monitoring is super important, especially with asthma. One really valuable tool is the peak flow meter.
Peak flow meter. I remember using one of those when I had asthma. It measures how fast you can blow air out, right?
Yep, it measures peak expiratory flow, or PEF. It's a good indicator of how open your airways are.
So high peak flow, open airways, low peak flow, constricted airways.
That's the gist of it. And the key is to establish your personal best peak flow, when you're feeling good, and use that as a baseline.
So if my peak flow starts to drop compared to my best, it could be a sign that my asthma is acting up.
Exactly. That's why it's so important to use the peak flow meter regularly and track those readings.
So how do those readings translate into action?
Typically, we categorize peak flow readings into green, yellow, and red zones.
Like a traffic light.
Exactly. Green zone means your asthma's under control, yellow zone means caution, and red zone means you need to seek medical attention.
So if my reading's in the yellow zone, I need to be more careful, maybe adjust my medications.
Right.
And if it's red, it's time to see a doctor.
Exactly. It's like having your own personal early warning system for asthma.
That's a great way to think about it. Now let's switch gears again and talk about pulmonary vasodilators.
Okay, so pulmonary vasodilators are a special class of drugs that target those blood vessels in the lungs, the ones involved in pulmonary hypertension.
Pulmonary hypertension. I know that's a serious condition, right? Where the blood pressure in the lungs is too high?
It is. Can be caused by several things like heart disease, lung disease, even some medications.
And pulmonary vasodilators help to lower that pressure so it's easier for the heart to pump blood through the lungs.
Exactly. They relax and widen those pulmonary arteries so blood flow improves.
One of the coolest pulmonary vasodilators I've heard of is inhaled nitric oxide, or INO. It's used for babies with PPHN, persistent pulmonary hypertension of the newborn.
That's right. In PPHN, the blood vessels in the baby's lungs don't relax after birth like they should, and that causes serious breathing problems.
So INO helps to relax those constricted blood vessels and improve oxygenation. It's like a breath of fresh air for those little lungs.
Exactly. And it can be a real lifesaver for those babies, often reducing the need for more invasive treatments.
It's amazing that we can just deliver a gas like nitric oxide straight to the lungs and have such a huge impact.
It really is. And while INO is primarily used for newborns, it's also sometimes used in adults with certain conditions like ARDS or pulmonary hypertension after a lung transplant.
That's interesting. What about iloprost? What's that one used for?
Iloprost is what we call a prostacyclin analog. Prostacyclin is a natural substance that helps to relax blood vessels and prevent blood clots.
So iloprost basically mimics those effects, specifically in the lungs.
Exactly. It's used to treat pulmonary arterial hypertension, which is a type of pulmonary hypertension that affects those arteries in the lungs.
And it's usually inhaled.
That's right. Iloprost can be very effective at improving symptoms and quality of life, but like many powerful medications, it can also have side effects.
So close monitoring is key. It's pretty amazing how we can target such specific areas in the body with medications. Pulmonary vasodilators offer real hope for people with pulmonary hypertension, which used to be a much more difficult condition to manage.
It's true. It really shows how far we've come in respiratory medicine.
Now, as we move into those critical care medications, we encounter some drugs that are essential for managing those really sick patients. And they come with some pretty heavy ethical considerations. We're talking about neuromuscular blocking agents, or NMBAs.
NMBAs, yeah, it's sometimes called paralytics. These are medications that cause temporary paralysis. They block those nerve impulses to the muscles.
So they basically prevent the muscles from contracting.
That's right. And they're mostly used in critical care settings for a few reasons.
Like when someone needs to be on a ventilator?
Exactly. Paralyzing the muscles helps to allow for more controlled ventilation.
Makes sense. Are there other times when NMBAs would be used?
Yeah, sometimes they're used to control intracranial pressure in patients with severe brain injuries, reduce oxygen consumption in certain situations, or prevent movement during those really delicate surgeries.
Sounds like they have some important uses, but I'm guessing there are some risks too.
Definitely. One of the biggest concerns is that they paralyze the patient without affecting their consciousness or ability to feel pain.
Oh, wow. So they're completely paralyzed but still aware of everything going on?
It would be terrifying, honestly. That's why it's absolutely crucial to make sure that patients receiving NMBAs are also getting adequate sedation and pain medication.
That seems incredibly important.
It is. There was this classic experiment done back in 1947 by Smith and his colleagues, where they paralyzed some healthy volunteers with an NMBA but kept them fully awake. It really highlighted how crucial sedation is.
What happened?
Well, those volunteers felt like they were choking and suffocating. They couldn't move or communicate. It was a really unethical experiment, but it showed how psychologically disturbing it can be to be paralyzed but still conscious.
That's a really good reminder to always think about patient comfort and dignity, even in critical care situations.
Absolutely. Now, there are two main types of NMBAs, depolarizing and non-depolarizing.
What's the difference?
Depolarizing NMBAs, like acetylcholine, work by mimicking acetylcholine, the neurotransmitter that tells muscles to contract. But instead of causing a brief contraction, acetylcholine makes those muscle fibers stay depolarized, leading to flaccid paralysis.
So it's like overloading those muscles with signals.
That's a good way to think about it. Non-depolarizing NMBAs, on the other hand, compete with acetylcholine for those receptor sites, so they block its action.
So they're blocking acetylcholine from reaching its target.
Exactly. Some common non-depolarizing NMDAs are rocuronium, vecuronium, and pancuronium.
And those tend to last longer than succinylcholine.
Right. They're often used for prolonged paralysis, like when a patient needs to be on a ventilator for an extended period.
And you mentioned earlier that there are reversal agents for non-depolarizing NMDAs. What are those?
So, reversal agents are basically medications that can quickly reverse the effects of those NMDAs. They help the patient get back their muscle control.
Oh, so it's like an undo button.
Pretty much. The decision of which NMDA to use depends on several things, the clinical situation, how long you need the paralysis to last, and the patient's overall health.
It's a balancing act for sure, making sure the patient is safe and comfortable. Now, let's talk about pain management and sedation in critical care. Pain is considered the fifth vital sign now, right?
It is, yeah. Managing pain is a huge part of patient care, especially in critical care, where patients are often experiencing a lot of discomfort.
And it's not just about relieving suffering, it also helps prevent complications.
Exactly. Uncontrolled pain can trigger all sorts of physiological responses, like increased heart rate and blood pressure, and that can make things worse.
So it's really about supporting their recovery.
Right. Now, we have a bunch of different ways to manage pain, and it depends on how severe the pain is, what's causing it, and the patient's individual needs.
Like, we have those non-pharmacological methods, things like repositioning, distraction, even music therapy. Are those effective?
They can be, especially for mild pain or in combination with medication. Sometimes something as simple as repositioning or dimming the lights can make a big difference.
Makes sense. And what about when medications are needed? What are our options?
Well, we have those nonsteroidal anti-inflammatory drugs, the NSAIDs, things like ibuprofen or naproxen. Those are usually used for mild to moderate pain.
I've taken ibuprofen for headaches and muscle aches. How do those work?
They work by inhibiting the production of prostaglandins, which are those inflammatory mediators that cause pain and swelling.
So they're like the firefighters putting out those flames of inflammation.
Exactly. Then there are the opioids, which are much stronger pain relievers used for more severe pain.
Opioids have gotten a lot of attention lately with the opioid epidemic. Are they still used in critical care?
They are, but very carefully. They can be really effective for pain, but they also come with some risks, things like respiratory depression, sedation, constipation.
And addiction.
Right, the potential for addiction is there. So it's all about balancing the benefits with those potential harms.
And making sure patients are carefully monitored. Morphine, fentanyl, hydromorphone, those are all common opioids, right?
There are. And they work by binding to those opioid receptors in the brain and spinal cord, which block those pain signals.
So they interfere with how we feel pain.
Exactly. But like I said, it's important to use them carefully.
Now, what about sedation? That's a common practice in critical care, too.
It is, yeah. Sedation helps to reduce anxiety and promote relaxation, which is really important for patients on a ventilator, for example. It keeps them from fighting the ventilator.
So it's not just about making them sleep, it's about creating a calm environment.
Exactly. And there are different levels of sedation, from minimal sedation, where they're awake and can respond to commands, to deep sedation, where they're unconscious.
What are some of the common sedatives used in critical care?
We use benzodiazepines, like midazolam and lorazepam, pretty often. Those enhance the effects of GABA, a neurotransmitter that calms the brain down.
So they boost the brain's own calming system.
That's right. And then there's propofol, which is an IV anesthetic often used for short-term sedation in the ICU.
Why propofol?
It works quickly and wears off quickly,
Yeah.
which makes it good for procedures or for when you need to adjust the level of sedation often.
It's like a quick on, quick off switch for sedation.
Yeah, you could think of it that way.
Yeah.
But like all medications, it has potential side effects, so we have to monitor patients closely.
Makes sense. So using sedatives in critical care involves a lot of careful monitoring and adjustments to make sure the patient's comfortable but not over-sedated.
Absolutely.
Now, shifting gears again, let's talk about anti-infective agents. Infections are a huge concern for critically ill patients, and we've got a whole arsenal of medications to fight them, right?
We do. Anti-infective agents include medications that target bacteria, viruses, fungi, and parasites.
It's like a whole army of specialists.
I like that. We have antibiotics, antivirals, antifungals, and antiparasitics, each one designed to fight a specific type of microorganism.
Let's start with those antibiotics. We've all taken antibiotics at some point for bacterial infections. What are some of the specific antibiotics used in critical care?
There are so many. And it really just depends on what type of bacteria is causing the infection, how serious it is, and the patient's overall health.
Yeah.
Some antibiotics target a narrow range of bacteria, while others are more broad spectrum.
So it's like choosing the right weapon for the battle.
Exactly.
Yeah.
For example, we have quinolones, like ciprofloxacin and levofloxacin, which are broad-spectrum antibiotics. They're effective against a wide range of both gram-positive and gram-negative bacteria. They're often used for respiratory infections, urinary tract infections, and skin infections.
I've taken ciprofloxacin for a UTI before. Worked like a charm.
It's very effective. Another group are macrolides, like azithromycin and clarithromycin. They mostly target gram-positive bacteria and are often used for respiratory infections like pneumonia and bronchitis.
Azithromycin, that's the Z-Pack, right?
That's the one.
Now, besides those oral and IV antibiotics, we also have those aerosolized antibiotics that go straight to the lungs.
We do. Those are especially useful for treating those chronic lung infections, like what you see in cystic fibrosis,
Why are they preferred for those infections?
because they deliver a high concentration of the drug right where it's needed without as many of those systemic side effects.
Like a targeted airstrike?
Exactly. One example is tobramycin, which is often used to treat Pseudomonas aeruginosa infections, particularly in CF patients.
I've heard tobramycin can be really effective, but has some potential for some pretty serious side effects.
Yeah, that's true. We have to monitor patients closely for things like hearing loss and kidney problems, especially if they're using it long term.
And aducanumab is another aerosolized antibiotic used for those Pseudomonas infections, right?
Yep. It's usually well tolerated.
It's incredible to think about how we can deliver medications straight to the lungs like that.
It really is. Now, shifting gears to those antiviral agents, those are the ones that target viral infections.
Right, like ribavirin. That one's used for those serious RSV infections in babies, right?
Exactly. RSV is a really common respiratory virus that's usually pretty mild in older kids and adults, but it can be really dangerous for babies, especially preemies.
Because it can lead to bronchiolitis, pneumonia, even respiratory failure.
Right. And ribavirin helps to fight the virus and prevent those complications.
And it's inhaled. Right.
It is. It's delivered through a special nebulizer, so it can reach deep into the baby's lungs.
But it sounds like treatment with ribavirin is pretty intense.
It can be. Often requires hospitalization, and it can actually pose risks to the healthcare providers giving the treatment, so they need to be careful.
So it's a powerful medication that needs to be handled carefully. What about zanamivir? What's that one used for?
Zanamivir is used for influenza, both type A and B.
The flu. We know that one all too well.
We do. Zanamivir is delivered through a special inhaler called a discaler. It delivered a fine powder of the medication to the lungs.
Interesting. So how does it work?
It basically stops those new viral particles from being released from infected cells, stops the virus from spreading.
Puts up a roadblock.
Exactly. Now let's talk about antifungal agents. Those are used to treat those fungal infections, which can be especially problematic for people with weakened immune systems.
Right, like people with HIV or who have had an organ transplant.
Exactly. Their immune systems aren't as strong, so they're more vulnerable.
One antifungal medication that comes to mind is pentamidine. I remember learning about that one. What's it used for?
Pentamidine is used to prevent and treat pneumocystis jirovecii pneumonia, or PJP. It's a serious lung infection that can happen in people with weak immune systems.
So it's protecting those vulnerable patients from a potentially deadly infection.
Exactly. It's given through a nebulizer. But just like with ribavirin, it needs to be handled carefully because it can pose a risk to the people giving the treatment.
Another powerful antifungal I've heard of is amphotericin B. That one's been around forever.
It has. It's been used for years to treat all kinds of serious fungal infections. It can be given intravenously or inhaled, depending on the situation.
So it's a pretty versatile medication.
And it is. But it can also have some pretty bad side effects. Things like fever, chills, nausea, even kidney problems.
So careful monitoring is essential.
Definitely.
Yeah.
It's a reminder that even those really effective medications can have downsides.
Now, before we move on, I think we should mention vaccines. They play a huge role in preventing infections in the first place.
Vaccines are one of the most important public health interventions we have. They've saved millions of lives.
Right. They work by training our immune systems to fight off specific pathogens.
Exactly. And we have vaccines that protect against a lot of those respiratory pathogens like influenza, pneumococcus, and pertussis.
The flu shot's one that a lot of people get every year.
That's right. It's updated annually to protect against those strains that are circulating each flu season.
And the pneumococcal vaccine's another one that's really important, especially for older adults and people with certain health conditions.
Yeah, it protects against streptococcus pneumonia, which can cause pneumonia, meningitis, and other serious infections.
It's amazing how vaccines can trigger our own immune systems to protect us.
It really is. Now, Before we wrap things up, we need to talk about cardiac medication. They're crucial for managing a whole range of heart conditions.
Okay, cardiac medications, bring it on.
They're used for treating and managing conditions like arrhythmias, heart failure, high blood pressure, and coronary artery disease. It's a huge area.
Lots to cover for sure. Let's start with those antiarrhythmic medications. What are those all about?
Those are used to treat abnormal heart rhythms. They work in different ways, but the goal is to restore a normal heart rhythm and prevent complications.
Arrhythmias can be scary. I remember having heart palpitations once, and it was a really weird feeling.
They can be, some are harmless, and some could be really dangerous.
What are some examples of those antiarrhythmic meds?
One that's commonly used is adenosine. It's given for a specific type of fast heart rhythm called supraventricular tachycardia, or SVT.
SVT, okay. How does it work?
It slows down the electrical signals in the heart, specifically through the AV node, which is the electrical pathway between the upper and lower chambers of the heart. It basically interrupts those abnormal signals that are causing the fast heart rate.
So it's like hitting the reset button on the heart's electrical system.
Yeah, that's a good way to think about it. And it's given as a really fast IV push because its effects are super short-lived, usually just a few seconds.
So it's in and out quickly. What about amiodarone?
Amiodarone is used to treat a wider range of arrhythmias, including atrial fibrillation, ventricular tachycardia, and ventricular fibrillation.
Atrial fibrillation or AFib, that's a really common arrhythmia, right?
It is. It's where you have this rapid, irregular electrical activity in the upper chambers of the heart. It can increase the risk of stroke.
That's scary. And ventricular tachycardia and ventricular fibrillation, those sound even more serious.
They are. They involve those abnormal rhythms in the lower chambers of the heart and can be life-threatening.
So amidarone's used for those really serious arrhythmias.
It is. It works by affecting different ion channels in the heart, which slows down those electrical signals and stabilizes the rhythm.
Sounds complicated.
It is, and it can have some pretty serious side effects, so we have to be really careful with it.
What about atropine sulfate?
Atropine's used to treat slow heart rhythms, also called bradycardia.
So if someone's heart rate gets dangerously low, atropine can speed it up.
Exactly. It works by blocking acetylcholine's effects on the heart. Remember, acetylcholine is part of that parasympathetic nervous system, that rest and digest system.
And one of its jobs is to slow down the heart.
Right. So atropine blocks acetylcholine, and that lets the heart rate increase.
Takes the brakes off the heart.
Good analogy. Atropine is often used in emergencies for bradycardia, asystole, which is when there's no heartbeat at all, and even for some types of poisoning that can cause a really slow heart rate.
Now, we've talked about medications that affect the heart's rhythm, but what about
Medications that affect the heart's pumping strength, we call those inotropic agents. They increase the force of those heart contractions, so they improve cardiac output.
right, cardiac output? So how much blood the heart pumps out with each beat?
Exactly. These inotropes are often used in critical care for patients with heart failure or shock, those situations where the heart's just not pumping well.
So they give it a boost.
Yeah, think of it that way. Two commonly used inotropes are dopamine and epinephrine.
Oh, epinephrine, that's adrenaline, right? The one that gets us all hyped up.
That's the one. And both dopamine and epinephrine work by stimulating those adrenergic receptors in the heart, specifically those beta-1 receptors.
And those are the ones that make the heart pump harder and faster.
Exactly.
Wow, our bodies are so complex, and it's amazing how we can use medications to influence those systems.
It really is. Okay, now let's talk about diuretics. Those are important for managing heart conditions, especially when there's fluid buildup.
Diuretics, those are the ones that make you pee more, right?
Yep, that's the simple way to think about it. They're often used for conditions like fluid overload, congestive heart failure, high blood pressure, anything where the body's holding on to too much fluid.
Right, fluid retention. I know that can cause swelling in the legs and ankles and even in the lungs, making it hard to breathe.
Exactly. One of the most common diuretics is furosemide, also known as Lasix.
Lasix, I've heard of that one.
Yeah, there's a loop diuretic, meaning it works in a specific part of the kidneys. It tells the kidneys to get rid of more fluid by preventing the reabsorption of sodium chloride so you make more pee.
So it's like opening up the floodgates in the kidneys.
Exactly. It works quickly, but it can also cause electrolyte imbalances, so we have to monitor patients carefully.
Makes sense. Now, on the opposite end of the spectrum, we have fluids used for resuscitation. What are those all about?
Those are crucial for treating hypotension, hypovolemia, and shock, and when there's not enough blood flow to those vital organs.
Like when someone's lost a lot of blood.
Yeah, exactly. Or if they're in shock, which can happen for all sorts of reasons, severe infections, allergic reactions, even heart problems.
And the goal of fluid resuscitation is to get that blood volume back up, improve circulation.
Exactly. It's all about getting enough fluid back into the bloodstream to keep those vital organs working.
And there are different types of fluids used for that, right?
There are. The two main types are crystalloids and colloids.
Crystalloids and colloids. Okay, break it down for me.
So crystalloids, like normal saline and lactated Ringer's solution, are just solutions of salts and sugars. Those are the first-line fluids for resuscitation in most cases.
So they're kind of like a basic electrolyte drink for your bloodstream.
That's a good way to think about it.
Hmm.
Colloids, on the other hand, contain larger molecules that tend to stay in the bloodstream longer, so they help to hold that blood volume and pressure up. They're usually used for more severe cases of hypovolemia or shock, or when crystalloids just aren't doing the trick.
So what are some examples of those colloids?
Albumin and hydroxyethyl starch are two common ones.
It sounds like choosing the right type of fluid and knowing how fast to give it is really important in critical care.
It is. It depends on what's causing the hypotension, the patient's condition, and other factors.
Right, because prompt and appropriate fluid resuscitation can truly be life-saving, especially in emergencies.
Absolutely. It's a cornerstone of critical care.
So we've talked a lot about different medications and their mechanisms of action, but it's important to remember that safe medication administration goes beyond just knowing the drugs.
Right.
There are certain principles and practices that are really important to minimize errors and ensure that patients are getting the right medications.
You're absolutely right. One of the most important principles is the 5 rights of medication administration.
5 rights. Okay, I'm intrigued.
The right patient, the right drug, the right dose, the right route, and the right time.
Seems pretty straightforward, but I'm guessing there's more to it than that.
There is. Let's break it down. Right patient means, making sure we're giving the medication to the correct person. Seems obvious, but it's really important to verify the patient's identity before giving any medications.
Especially in a busy hospital, it's easy to get mixed up.
Exactly.
Yep.
Right drug means double-checking that we're giving the medication the prescriber actually ordered. We need to check the order, the medication label, and the patient's allergies before we give anything.
So it's all about being really thorough.
Attention to detail is so important.
What about the right dose?
That's making sure we're giving the correct amount of the medication, as ordered. We need to pay attention to the units of measurement, calculate those doses accurately, and double-check our work.
No eyeballing it.
Right. Then we have right route, which is the method of administration: oral, intravenous, intramuscular, inhaled, or topical. We need to make sure we're giving it the right way.
And lastly, right time.
Right time means making sure those medications are given at the correct times, which might mean taking into account things like whether it needs to be given with food or on an empty stomach.
So it's about sticking to the schedule and paying attention to any special instructions.
You got it. These 5 rights might seem basic, but they're really crucial for preventing errors.
Absolutely. It's all about keeping our patients safe.
And beyond the 5 rights, there are other important things to remember, like understanding those abbreviations used in medication orders.
Oh, yeah. Like BID for twice a day, TID for 3 times a day.
Exactly. And QUID for 4 times a day, PEAT for as needed, and STAT for right away. Those are all super important to know. We also need to think about potential drug interactions.
Drug interactions. So that's when 2 or more medications might interact with each other.
That's right. And those interactions can either make the medication stronger or weaker, depending on what they are.
So some interactions can make medications less effective, and some can increase the risk of side effects.
Exactly. And in some cases, those interactions can be really dangerous.
So always check for potential interactions and talk to a pharmacist or other healthcare provider if you have any questions.
Always better to be safe than sorry.
Well, we've covered an incredible amount of information in this deep dive into pharmacology. From those basic principles to the complexities of medication administration, we've really explored a lot.
We have. It's such a fascinating field.
It is. It makes you really appreciate the power of scientific discovery and how much dedication goes into developing new medications and treatments.
Absolutely. I've no doubt there are even more incredible advancements coming in the future of pharmacology.
Me too. Well, thank you for joining us on this journey through the world of pharmacology. It's been an incredible learning experience. Until next time.